Hello everybody, I am Dr. Lamyaa Allam, an Associate Professor of Cardiology and Cardiac Electrophysiology and Cardiac Pacing at Ain Shams University, and I will discuss with you today a lecture about the atrial tachycardias, how to diagnose and manage as a part of module of cardiac arrhythmias part 2. I will try to cover these points during our session. I will define the atrial tachycardia, the classifications and the mechanism of atrial tachycardia, especially focal atrial tachycardia, localization of the focus and the site of atrial tachycardia through the ECG, how to manage, and I will give a short summary about the other forms of atrial tachycardias. What is atrial tachycardia? Atrial tachycardia is a supraventricular tachycardia arising from the atria, doesn't require participation of the AV node, junction, accessory pathway, or ventricular tissue to initiate and to maintain this tachycardia. How to diagnose this atrial tachycardia? It is characterized by regular organized atrial activity, which is reflected on ECG by clear, discrete B wave. And there is an important point that these B waves are separated by the isoelectric segment. This is differentiate the atrial tachycardia from the atrial flutter, because in the atrial flutter we see saw-toothed appearance, flutter waves like B wave, but there is no isoelectric segment between these B waves. But in atrial tachycardia, there is a characteristic isoelectric segment among these B waves. And this ECG shows an example of a case with atrial tachycardia. The atrial tachycardia is a narrow complex tachycardia, long RB tachycardia. What is meant by long RB tachycardia? It means that the RB interval is longer than the BR interval on ECG. It is characterized by heart rate around 100 beats per minute to 250 beats per minute. And as I said before, we see a discrete P wave with P waves in the ECG with isoelectric segments separating between each P wave from the other. This tachycardia, in most of the time, regular tachycardia, when the B waves is transmitted through the AV node to the ventricle in 1-1 conduction pattern. But sometimes when the atrial activity is very fast, not all the beats from the atria conducted through the AV node to the ventricle because of the fatigue of the AV node. So we sometimes see this tachycardia in irregular pattern when there is a variable AV conduction. And this pattern, we see it commonly in patients with atrial tachycardia who takes medications like AV nodal blocking agents or antiarrhythmic drugs. And this ECG shows an example for atrial tachycardia with variable AV block. And as we see in this ECG, we see in the lead 1, there is the first beat shows B wave followed by QRS complex. And the second beat shows a B wave followed by QRS complex. But the third B wave, not conducted through the AV nodes, there is no QRS complex, followed by another B wave, followed by a QRS complex. This is a variable block. And this is a third example for the atrial tachycardia with variable block. As I see, marking by an arrow on the B waves, and we see there is another B wave up before this, the B wave marked by arrow, not followed by QRS complex. We know now how to diagnose the atrial tachycardia. What is the classification of the atrial tachycardia? Atrial tachycardia, it may be either ectopic or focal atrial tachycardia, macro reentrant atrial tachycardia, or Sinoatrial reentrant tachycardia. I will not discuss in this session the macro reentrant atrial tachycardia because macro atrial tachycardia is a part of atypical atrial flutters, which will be discussed later in a session about the atrial flutter. And I will concentrate in this session about the other forms of atrial tachycardia, the focal atrial tachycardia and the Sinoatrial reentrant tachycardia. What is focal atrial tachycardia? Focal atrial tachycardia is an atrial tachycardia that arises from a localized area focus in the atria, either from the left atrium or the right atrium. Its mechanism, either automatic or enhanced automaticity, triggered activity or micro reentry. And the B wave morphology and axis on ECG depend on the site of this focus from which the tachycardia originates. And the question here, how to differentiate or know the mechanism of ectopic atrial tachycardia? It is either automatic atrial tachycardia triggered or micro reentry. Automatic atrial tachycardia is characterized by important phenomena, which is warm-up phenomenon. What is meant by warm-up phenomenon? Means that this tachycardia is initiated gradually and terminated gradually. It is initiated by gradual increase in its rate and terminate by gradual decrease in its rate. And one of the most important characteristics of this atrial tachycardia that it doesn't respond to the DC shock or electrical cardioversion in the ER. When you find these phenomena, the mechanism of the atrial tachycardia is most probably an automatic atrial tachycardia. While the triggered atrial tachycardia, it is due to delayed after depolarization, and usually it is associated with digitalis toxicity or conditions associated with sympathetic overactivity and increase in catecholamines. And this mechanism is the mechanism of a special form of atrial tachycardia, which is called multifocal atrial tachycardia. What about the micro reentry atrial tachycardia? Micro reentry atrial tachycardia is a very small reentry inside a localized focus in the atrium. And it is characterized by that it arises or initiated suddenly and terminated suddenly. There is no warm-up phenomenon in the micro reentry atrial tachycardia as in the automatic atrial tachycardia. And this mechanism is responding well to the DC shock, and DC shock can terminate this tachycardia. This is how we can differentiate the different mechanisms of ectopic atrial tachycardia. Then, when a patient came to the ER with arrhythmia and you diagnose this arrhythmia as an atrial tachycardia, how can I differentiate or know the mechanism of this tachycardia? I can use a famous medication which is known as adenosine. Adenosine, I can give it intravenously, and according to the response of the atrial tachycardia, I can know its mechanism. When I see that there is a gradual slowing of the arrhythmia, then reacceleration to its initial or its basal tachycardia cycle length, it is most probably an automatic focal atrial tachycardia. But if the tachycardia is terminated suddenly, it's most probably a triggered activity. But if I give adenosine and see that the tachycardia doesn't stop, but it is persistent, and sometimes occurs some variable AV conduction or AV block, it is most probably a micro reentry atrial tachycardia. The third point I will discuss today, how I can detect or find the site of the focus of atrial tachycardia through the ECG. Atrial tachycardia has a characteristic anatomical distribution and common sites that I should know before I see the ECG. In the right atrium, the most common sites for ectopic atrial tachycardia is crista terminalis, coronary sinus, ostium, septal origin, tricuspid annulus, right atrial appendage. While in the left atrium, the common sites of ectopic atrial tachycardia is the ostia of the 4 pulmonary veins, and this is the common site of ectopic atrial tachycardia in around of 80% of the cases of left-sided atrial tachycardia, and the other rare site is the mitral annulus and left atrial appendage, and the rarest form of left septal atrial tachycardia. There are many algorithms published over the years to detect the site of atrial tachycardia, but the most important algorithm which is published by Kessler et al. In JACC in 2006. It is more detailed algorithm, and its accuracy and specificity reaches around 80%. It depends on the morphology of the B wave in lead V1. It tells us that if the V1 B wave in the lead V1 positive, it is most probably a left-sided atrial arrhythmia or atrial tachycardia. But if it is negative, it is most probably from the right side. And then we see if the B wave positive in V1, I should look to the B wave as the inferior lead. If it is negative, it is most probably either from coronary sinus body or from the left pulmonary veins or left atrial appendage. But if it is not bifid, the sinus rhythm B wave, I should compare it with the B wave during the tachycardia. If I see the P wave in the inferior lead positive, it is most probably from cisterna terminalis or right pulmonary vein. If it is not positive, negative, it is most probably from right pulmonary veins. While if the B wave in the lead V1 negative, as I said, it is most probably from the right side or the right atrium. I should see the precordial lead. If the precordial lead, the B wave positive from V2 to V4, it is most probably a crista terminalis. If it is positive, I should see the B wave in the inferior leads. If it is negative, it is tachycardia arising from the tricuspid annulus. If it is positive, it is a tachycardia arising from the right atrial appendage. If it is the B wave biphasic in V1, positive, negative, it is started by positive deflection, it is a crista terminalis. If it is negative positive, it is either from the mitral annulus or from the coronary sinus ostium, and I can differentiate between them through the B wave in the lead EVL. If it is negative, it is a left-sided focus from the mitral annulus. If it is positive, it is a right-sided from the CS ostium. And these some examples for how to localize the focus of atrial tachycardia through the ECG. As I said before, we should see the B wave in the V1. If it is positive, so it is most probably a left-sided focus. Then I will see the inferior leads, the B wave in the inferior lead. Is it bifid or not? In this example, it is not bifid. So it is a negative. When it is a negative with positive B wave in V1, it is most probably an atrial tachycardia arising from coronary sinus ostium. Here I see a positive B wave in the V1, which is bifid, notched, and I see a positive B wave in lead 2, 3 AVL, and it is bifid 2, so it is most probably a focus arising from left superior pulmonary vein. And this is the last example. I see a negative B wave in the V1 and negative B waves in the inferior leads and in the precordial leads, so it is a tricuspid annulus focus. This is another paper published by our team at Ain Shams University Hospital by me and my colleagues to detect how to differentiate between the very close sites of atrial tachycardia from the lower part of the right atrium, from the coronary sinus ostium and tricuspid annulus, lower part of the crista terminalis, and lower part of the free wall of the right atrium. And we test or studied the role of the precordial leads for differentiation between them as they are so close or similar in the algorithm of Kessler. And we find that the precordial leads is from V2 to V6 are negative in the tricuspid annulus and the coronary sinus ostia atrial tachycardia, while it is positive in the lower part of the crista terminalis. And we can differentiate between coronary sinus ostium and tricuspid annulus atrial tachycardia through the B wave in V1, that it is negative in tricuspid annulus atrial tachycardia, while it is positive in the coronary sinus ostium atrial tachycardia. So the ECG is very, very important in the atrial diagnosis of atrial tachycardia, but it is used only for diagnosis and localization of atrial tachycardia. No, the ECG is a cornerstone for many points in management of atrial tachycardia. I can diagnose the atrial tachycardia. I can know the mechanism, as I said before. If I see a warm-up phenomenon on ECG, it is most probably on automatic atrial tachycardia. pattern if the patient has a paroxysmal attacks of atrial tachycardia or incessant or persistent atrial tachycardia. This will reflect on my decision on how to manage this patient, and if the tachycardia is incessant, the patient has a higher risk of having a tachycardia-induced cardiomyopathy. And finally, I can localize or know the site of atrial tachycardia. And this is very important for us as a cardiologist when we decided to do an EP study and ablate this focus. I should know preliminarily the diagnosis of this focus by ECG. The next point, we will discuss the presentation of the patient with atrial tachycardia. Most of the patients have structurally normal heart. This tachycardia came to the patients with normal hearts, and the patient has symptoms like palpitations, syncope, pre-syncope, dizziness, lightness, as any other arrhythmias with a fast heart rate. But sometimes the patient's asymptomatic, and this tachycardia discovered accidentally during routine evaluation or a checkup. The atrial tachycardia, it can occur in adults and in children. It is one of the common arrhythmias that occurs in pediatric population. It represents around 10 to 15% of supraventricular arrhythmias in children. And it can present it even in neonates and during fetal life. And when it is presented in fetal life, unfortunately, it is in incessant form, and this is a high risk for development of myopathy later on after labor. In neonates, it represented by difficulty in breathing, not gaining weight, and if this tachycardia became incessant or not responding to medications, the patient has a high risk for development of tachycardia-induced myopathy, and he will be presented by symptoms of heart failure. So it is very important to know how to diagnose and how to manage these arrhythmia. When we're dealing with arrhythmia, we should know two terminologies in the management: the acute management and long-term management. Acute management means that the patient came to me symptomatic in the ER or in my clinic, and he has the arrhythmia right now, and I want to improve his symptoms. While the long-term management means that I will give a medications or I will do a procedure to prevent the recurrence of this arrhythmia again. Acute management: how to manage these patients when they came symptomatic from atrial tachycardia. As any arrhythmia, the most important point is the hemodynamic stability of this patient. If the patient has hemodynamic instability, either hypotensive, shocked chest pain, I should give DC shock. If it is effective, so it's end. But if it is ineffective, like in cases of automatic atrial tachycardia, so I will give medications. But I will give a medication that doesn't affect the blood pressure, like antiarrhythmic drugs class 1C or class 3, antiarrhythmic drugs like flecainide, propafenone, or amiodarone, IV, because I want a rapid response. But if the patient came to me symptomatic by palpitation or dizziness, but he hemodynamically stable and his blood pressure is okay, I can give him an IV medications, which is usually an AV nodal blocking agents like beta blockers, as class indicated as a class 2A, or calcium channel blockers. If these medications are ineffective, I will give him an antiarrhythmic drugs, as I said before, either class 1C or class 3 antiarrhythmic drugs. And this management is according to the last guidelines published by European Society of Cardiology in 2019 for management of arrhythmias or supraventricular tachycardias. What about the long-term therapy or the maintenance therapy to prevent the recurrence of this tachycardia? The most important, you should answer 3 questions before you choose the way to manage. Is this tachycardia came in paroxysmal patterns or it is incessant and persistent? And I can know this by ECG and Holter monitoring. Is this patient is child or adult? The patient has a structural normal heart or structurally abnormal heart. And this is the last the management, which is last from the latest guidelines of European Society of Cardiology, and say if the tachycardia is recurrent or incessant, I should send the patient to the electrophysiologist and do an AB ablation as a class 1A in 1B indication. If the tachycardia is not recurrent or incessant, so I can give him an oral medications. If the patient refusing to take a medication of the tachycardia not responding to the medications, I should send him for ablation. If responding to medications or the patient wants to take a medication or it is not incessant, I can give him medications like beta blockers, calcium channel blockers, or class 1C antiarrhythmic drug like flecainide. If there is no response for these medications, I can give him ivabradine in association with beta blockers. But this is a class 2B. It is better to send him for ablation. And the last medications that I can give is amiodarone. But we don't prefer amiodarone because of its side effects on long term, especially if I am dealing with a child. There is 2 points when I deal an atrial tachycardia with a child. First of all, the preferred medication is the beta blocker. The second one is the class 1C. But I don't prefer calcium channel blocker, especially in children less than 2 years, because it can cause an severe or marked unexpected hypotension in this age group. And of course, we didn't prefer amiodarone in a child because of the long-term side effects of amiodarone. So if the tachycardia is not responding to medication, it is better to send the patient for ablation. Especially that the success rate for ablation of atrial tachycardia is exceeding 98% because of the advances and the technologies in the techniques of ablation. This tachycardia, we can ablate it either by conventional way or by using 3D mapping system, which raises the success rate of ablation of these arrhythmias. So don't hesitate to send your patient to an electrophysiologist when the tachycardia is incessant, recurrent, not responding to medications, or there is a tachycardia-induced myopathy from this tachycardia. I finished my session about the focal atrial tachycardia. And now I will start with the other forms of atrial tachycardia. One of them is the Sinoatrial reentrant atrial tachycardia. It is a subset form of ectopic or focal atrial tachycardia due to a micro reentry arising within the SCE node. And according to this, because it arises from the SCE node, the B-wave morphology and the axis is similar to the sinus tachycardia. So the question here, how to differentiate this arrhythmia from the sinus tachycardia? There is a differential diagnosis for sino-reentrant atrial tachycardia. Is the inappropriate sinus tachycardia and the POTS disease, Butcher orthostatic tachycardia. How I can differentiate between these forms of presentation by an ECG similar to sinus tachycardia? First, I should dealing with them as a sinus tachycardia and searching for causes for sinus tachycardia, reversible causes like anemia, like thyroid disease. If there is no reversible causes, so it is either inappropriate sinus tachycardia, cyano-reentrant atrial tachycardia, or postural orthostatic tachycardia. I can diagnose the postural orthostatic tachycardia from the presentation that it came in attacks, and it can be diagnosed by telltale tests. While the Sinoatrial reentrant tachycardia and inappropriate sinus tachycardia are very similar, and I can know it except by EB study. So their management is so similar and their management is the same. So according to the guidelines of European Society of Cardiology, they said if you have a case with incessant or inappropriate sinus tachycardia, I should first searching for reversible causes. If there is no reversible causes, I can start by beta blockers as a class 2A or ivabradine, which is known as a proclolan. If there is no response or still the patient is symptomatic, I can make a combination of these medications together. I can give an ivabradine with beta blockers, or I can, if there is no response or the patient is still symptomatic, I can add a verapamil or diltiazem. Finally, I send the patient to the cath lab for catheter ablation. But in the catheter ablation, it is very difficult to treat it finally, and sometimes I do what is called the modification of the SC node to decrease the heart rate, but sometimes I can't ablate the SC node completely to not make the patient has a SC nodal plaque and insert a pacemaker. So the catheter ablation is the last step in this type of arrhythmia. Another form of atrial tachycardia is the multifocal atrial tachycardia. Multifocal atrial tachycardia is a unique type of atrial tachycardia in which there is more than one focus arising from the atria that acting together at the same time. And in this tachycardia, I see on ECG irregular narrow complex tachycardia with different P-wave morphology, at least 3 or more P-wave morphologies with variable PR interval, as I see in this ECG. But sometimes this arrhythmia is very commonly to be misdiagnosed as atrial fibrillation. So it is most important to know how to differentiate between them. As I said, in multifocal atrial tachycardia, I see a discrete P-waves with 3 different morphologies and the isoelectric segment between them. But in atrial fibrillation, I can see a discrete P waves or isoelectric segments between these waves. Why it is important to differentiate between them? Because in multifocal atrial tachycardia, I don't need to give the patient an oral anticoagulant. While in atrial fibrillation and atrial flutter, he should receive an anticoagulation. The multifocal atrial tachycardia, it is commonly has a reversible causes to terminate it, and it is commonly occurs due to underlying associated diseases, especially the chest conditions like pulmonary diseases, metabolic or electrolyte disturbances, and it occurs sometimes with digitalis toxicity. So the most important point for management is to treat the underlying cause as a class 1 indication. Sometimes I can use a medications to decrease if the patient is symptomatic from this tachycardia, like IV beta blockers or IV calcium channel blockers to do an AV block and to terminate this tachycardia. Sometimes if the patient has a chronic condition that causing multifocal atrial tachycardia, like a chronic obstructive disease of the chest, I can give him an oral or maintenance therapy, as I said, like calcium channel blockers or beta blockers. But most important thing to know that the calcium channel blockers is contraindicated in patients with impaired ejection fraction less than 35%. So it is important to know if the patient has structural heart disease or not, and the ejection fraction is less than 35% or not. If the patient has refractory multifocal atrial tachycardia, and this patient has an LV dysfunction due to this tachycardia or due to the structural heart disease, I can and not responding to medications, I can sometimes do an AV nodal ablation and insert a pacemaker to this patient to prevent the deterioration and appearance of the symptoms of the heart failure. This is the management of multifocal atrial tachycardia. So, my take-home message today about the atrial tachycardia, that the ectopic atrial tachycardia is a common form of supraventricular tachycardia that can occur in both pediatric and adult population. It is one of the common causes of the tachycardia-induced myopathy, especially in children, and its diagnosis mainly depends on ECG criteria, either by 12-lead ECG or Holter monitoring or continuous ECG monitoring, and the ECG is the cornerstone for diagnosis of atrial tachycardia, for detect the site of the atrial tachycardia, to know the pattern of atrial tachycardia and decide the management of this atrial tachycardia. And you should know that the ablation of atrial tachycardia has a high success rate and is one of the main lines of treatment, especially in incessant or recurrent atrial tachycardias that not responding to medication in cases of tachycardia-induced myopathy. This is all I want you to know about the atrial tachycardia, and I finished my presentation, and I hope that it will a fruitful presentation for you, and thank you.